So we have Dr. Faisal. We'll introduce the speakers as and when the topic starts. We have Dr. Faisal from PGH Chandigarh. He's going to enlighten us with the cornea, how cornea is relevant to us in today's glaucoma practice. Over to you, Dr. Faisal.
Very good morning, everybody, and thanks Dr. Satyan and GSI for giving an opportunity to talk this topic, that is the corneal hysteresis and biomechanics in concomitant glaucoma diagnosis. As we know, few decade, maybe a decade back, when the aura came into the market, there was a lot of enthusiasm for this corneal biomechanics and corneal hysteresis. There were a lot of mushrooms of publications in corneal biomechanics. Then after 2013, this publication number has come down, and there is a kind of stagnant kind of thing. Then whenever new machines came like Corvus ST, there are few publications came about corneal hysteresis. So I'll be just talking about a little bit introduction of the corneal biomechanics and the how we can fit this into the day-to-day practice. So as you know, biomechanics for any substance or in corneas means the assessment of the deformation and the equilibrium of corneal tissue under any kind of application of the force. We know our cornea has good two properties, that is the elasticity and the viscous behavior. Both are essential for for the corneal day-to-day functions. So the elasticity, that is the main load of bearing this stress, that is by the collagen fibers, and the extracellular matrix, that is the ground substance, offer its viscosity. So what is corneal biomechanics? As we know, CCT says static parameters, but corneal biomechanics like corneal hysteresis, corneal resistance factors, these are not mechanical static factors, these are dynamic in nature. The measurement is also affected by the type of the stress and the rate at which the stress applied, location of the cornea where the stress applied, and the IOP, as well as the age and the axial length also. So for glaucomatologists, what is important relevance of glaucoma, this corneal hysteresis in our day-to-day practice? So corneal biomechanics may play a important role in the maybe an accurate measurement of the IOP, which is the only modifiable factor as of now, or this can be used as a global surrogate marker of the eye. That means we cannot measure the compliance or corneal biomechanics of the lamina cribrosa. So corneal biomechanics can have a surrogate marker of the overall globe biomechanics. So as I already told, there is two instruments mainly used. The initial one, the ocular response analyzer, started in 2006. Then lot of studies, or more than 500 studies, you can index studies, you can get ORA related in corneal biomechanics. And the later on Corvus came, and a few studies also came in the Corvus also. So what is hysteresis means? This is the viscous damping ability of the cornea. Or in simple word, hysteresis means lagging behind. That is the difference between how a material deform and reform during loading and unloading from an applied force, as shown in this picture. Then what is the normal value? Normal value is 9.6 to 10.7 millimeter of mercury. So in simple term, eye with low corneal hysteresis would have a poor shock absorption properties. That means this eye, eye with low corneal hysteresis will have more prone for IOP induced stress and strain and the subsequent glaucoma damage. So what is the impact of corneal CCT on corneal hysteresis? CCT in a normal healthy subject, there is a strong positive correlation with CCT and corneal hysteresis. But in practice in glaucoma patients, though there is a positive correlation, but the correlation between the corneal hysteresis and CCT is weak positive correlation. So I searched this, how we can fit this into our day-to practice. We have at least more than 500 indexed publications which studied about the corneal biomechanics. So how IOP affect the corneal hysteresis? IOP is negatively correlated with corneal hysteresis, such that high IOP, there is a lower corneal hysteresis. As the IOP increases, the cornea becomes stiffer and its damping ability reduces. But in other scenario, as in chicken and egg scenario, low IOP means, low corneal hysteresis means more stiffness. That means more stiffness means you need more force to applanate or indent. So that means you are recording, you may getting a high IOP recording. So that's why the relation between the IOP and the CCT is not like a straightforward. That means IOP increases, corneal hysteresis decreases. That is not the real scenario. So what the literature said that in POIG, all studies agreed that there is lower corneal hysteresis as compared to the healthy control. We also conducted a study in 2012. That study also agreed this same finding. POIG has less corneal hysteresis. While in NTG, the pressure is normal, but the corneal hysteresis is also less as compared to a normal person. But the NTG corneal hysteresis are slightly higher than the POG eyes. So that means low hysteresis, low compliance, and these eyes are more vulnerable for even get a normal pressure also. Whereas in ocular hypertension study, most of the studies recorded that there is high IOP and high corneal hysteresis. Whereas our study, we found that the corneal hysteresis is almost equal to normal person and with normal IOP. But that means high corneal hysteresis means there is the cornea has a effectively buffer the potential harmful fluctuation. That means the corneal compliance is, ocular compliance is good, and there can be tolerate more pressure. That is good for the particular eye actually. So what about the glaucoma progression? All studies, most of the studies agreed that corneal hysteresis was found to be significantly associated with the rate of the visual progression. That means, by and large, each 1 millimeter lower of corneal hysteresis associated with 0.25% per faster rate of visual field index decline. And how it affects the corneal structures, as I already mentioned that high corneal hysteresis means there is more stretchability and more compliance to the posterior segment, posterior part of the eye, especially in the lamina cribrosa and the optic disc area. This suggests that high corneal hysteresis are better able to tolerate the IOP spikes. Conversely, corneal is significantly lower in the primary open angle glaucoma patients. So if you do treatment for glaucoma, what happens is that the corneal reducing the IOP, corneal hysteresis will be increases. That has noted in many studies, but there is controversy also. Sometimes with the high IOP, there is corneal edema also. On decreasing the corneal edema, corneal biomechanics can also changes. So this is a controversy statement. So in day-to-day practice, can we use for risk profiling? Yes. Corneal hysteresis can help for risk profiling together with IOP and CCT. For example, in case of an ocular hypertension, if the corneal hysteresis is low and the pressure is high, and then we have to follow this patient more carefully as compared to a patient with normal corneal hysteresis or high corneal hysteresis with the high IOP. Similarly, in NTG also, there is corneal hysteresis is low with a given normal IOP. That means these patients need more follow-up, more close attention also. That's why I told that the corneal hysteresis is an IOP non-dependent factors for glaucoma. That means in POIG, in untreated POIG with high IOP, corneal hysteresis is low, whereas in untreated NTG with normal IOP, hysteresis is low, and again the other side, untreated ocular hypertension, corneal hysteresis is high. That means corneal hysteresis is not IOP dependent. And if the IOP patient is progressing, even with your best effort, you just can think about the corneal hysteresis. You can reduce your target IOP if the corneal hysteresis is low. And of course, the patient is with low corneal hysteresis for a given IOP need more attention than a patient with corneal is normal or high corneal hysteresis. So to summarize, corneal biomechanics are dynamic in nature, is not a static component. The relation between corneal hysteresis and IOP and or CCT is not straightforward in glaucoma patients. It can be used as a surrogate marker for measuring the corneal hysteresis of the lamina and optic nerve head, can be used as an IOP independent parameters, and is useful in risk profiling and setting the target IOP in day-to-day practice, especially if the patient is progressing even in your best effort after controlling the IOP with medication or surgery.